Good morning. I'm Divyangini Lal, and on behalf of Art of Work, it is my pleasure to welcome you to what I am sure will be a lively and informative conversation today. COVID-19 has impacted our lives in every way imaginable. Our governments, businesses, and broader communities are responding, adapting, and in many cases, enduring the efforts to overcome the effects of the virus on our lives. Today, our assembled panel of experts will consider the question. Perhaps our government should approach this crisis differently? We have 5 renowned thought leaders on our panel today who will analyze and share their views as to the effectiveness of the traditional safety one strategies currently being deployed by our government to combat the COVID-19 infection rates. The panel is keen to get your input into today's conversation, so please use the chat function within this YouTube live session to post your questions during the panel discussion. I'll attempt to direct as many of these as I can to the panel to discuss. I won't be able to get all your questions during the initial discussion. However, when I draw the panel conversation to a close, our panelists will remain online and will use the YouTube live chat function to respond to as many further questions as we can during our time together today. So without any further ado, let's meet our panel. Firstly, let me introduce Kelvin Genn. Kelvin is Art of Work's Managing Director. Formerly, he was the New South Wales Health Director for Clinical Quality and Patient Safety. He has also worked with the Australian Commission on Safety and Quality in Healthcare to develop the national accreditation system for all healthcare providers across Australia. Welcome, Kelvin.
Hi, Giddy.
Next, I would like to introduce Sue Urachi. Sue is a specialist emergency physician who has held positions in management, medical regulation, and health system consulting over a long clinical career. She now works in emergency telemedicine, which has further broadened her perspective on risk aversion and how risk is siloed between services. Welcome, Sue.
Thank you.
We are also joined this morning by Michael Tuma. Michael is the managing partner of Clyde & Co Australia. He is internationally recognized as one of the preeminent health and safety lawyers in the region. Michael is the leading advisor on COVID mandatory vaccination in Australia. He is advising high-profile businesses to navigate legal obligations and risks in relation to the COVID vaccination of their employees and other on-site personnel. Welcome, Michael.
Good to be here.
It gives me great pleasure to welcome our next panelist, Mary Louise McLaws. Mary Louise is a professor of epidemiology, hospital infection, and infection disease control at the University of New South Wales. She was appointed to the WHO Health Emergencies Program Experts Advisory Panel for Infectious Control for COVID-19 in February of 2020. Previously, she was the WHO advisor to China and Malaysia for surveillance and an expert advisor to WHO on several global projects for many years. She has worked on the HIV pandemic, reviewed the response to the SARS 2003 outbreak in Hong Kong and in Beijing, and assisted the Australian preparedness for the influenza pandemic. Outside pandemics, she works in patient safety, reducing the risk of infection in hospitalized patients. She has capacity-built surveillance, patient safety, and outbreak control programs in low and middle-income countries. Welcome, Mary Louise.
Thank you for having me.
And last, but by no means the least, it's my pleasure to welcome Professor Sidney Dekker to the panel. Professor Sidney Dekker is a professor at Griffith University in Brisbane, Australia, where he runs the Safety Science Innovation Lab. Sidney has won worldwide acclaim for his groundbreaking work in human factors and safety. He coined the term safety differently in 2012, which has since become a movement. Sydney is also the best-selling author of a plethora of required reading books, which include The Safety Anarchist, Just Culture, Safety Differently, and Drift into Failure. Welcome, Sydney.
Happy to be here, Guinea. Thank you.
Once again, thank you all. And let's kick off this panel discussion. I'd like to pose this question first to Sydney. In what sense are the current COVID measures safety one?
Oh, anything that imposes a compliance demand from the top down, anything that sees people as the fundamental problem to control, whose compliance is something that we need to control. And of course, anything that measures its own success by the absence of negative events is safety one. And we see all that in current COVID measures.
I might come to Michael. Michael, maybe you can give us a legal perspective.
Yeah, thanks, Guinea. I agree with everything that Sydney has said, and I would add that what's unique about the approach that we've taken in relation to the pandemic is that in many respects it is a return to a prescription-based approach where you prescribe certain rules rather than take a principled approach where you put forward a principle and objective for organisations to follow, at least so far as the organisations and company obligations are concerned. And with that comes the problems of having to constantly check the rules as they sit on a particular day and to constantly be across the changes for the rules to only apply to the things that are defined and in the way in which they're defined, and for the need to constantly redefine them and change them. And I'm sure we'll get into that debate today in terms of the difficulty and challenges associated with the large volume of rules that people need to be across and the impact that it has in relation to compliance and also acceptance of that approach.
Sure. And Kelvin, do you have some thoughts?
Yeah, again, no, obviously agreeing with both Sydney and Michael in that context. And I think, one of the features of Safety One is really trying to solve and control the problem that we're facing within the domain of, a select group of subject matter experts. And our principle being in Safety Two is that harnessing, the people who work at the coalface, the people who've got something to contribute, and seeing actually that the workforce out there as a solution to harness is a point of difference. So I think in our current approach, we have rested, quite clearly on the input of those subject matter experts and are not really taking the opportunity to harness some of these broader inputs.
Sure. I think, sorry, Kelvin, you touched on that, but just to expand on that slightly, if we took a safety differently approach at the outset, or as it became apparent that we would experience this sort of for a prolonged period of time in the form of waves, what would that have actually looked like?
I think the principal difference from my perspective is around engagement and trust. By building engagement and trust, so this is a huge problem. It's a very intractable problem that the governments are trying to solve in a range of different ways. But to some degree, they haven't harnessed a lot of the other expertise that could be. And I'm talking about non-traditional expertise, that it's not related to the medical expertise, but also expertise in industries that look at how do we solve the operational context, what's some of the different thinking, what are some of the ideas that we can harness, and how can we share with you the knowledge that is held within the subject matter experts to those other interested groups who have something to contribute and collaborate together to actually think we might come to some surprisingly different options in that space.
Sure. It might be helpful for our viewers if we take a single issue, for example, a vaccine mandate, and to hear your views as to where that sits, whether with respect to Safety One or Safety Two. I think, Michael, if you could answer that question.
Yeah, sure. I'm conscious. I'd be interested in hearing from both Mary Louise and Sue on some of those issues as well. And I know Mary Louise my co-author, Mary Louise, has a lot of views on vaccines. But for me, looking at vaccination as a safety 1 or safety 2 discussion kind of disguises the nature of what vaccination is. And the best way to characterize a vaccination is an isolation control. And so in many respects, it is a much higher, much more effective control up the hierarchy of controls than many of the controls we're currently deploying at the moment, which are more in the administrative control, social distancing, for example, or wearing of masks and other forms of personal protective equipment. Now, one of the things we know from years and years of safety, whether it's patient safety or health and safety, frankly, that the lower you are in the hierarchy of control, the less you are in the systemic and safety by design kind of solution phase, and the more that you are really very much tempted by a blame the worker or blame the person or blame the victim cycle. The reason for that is because we know that PPE or social distancing, whether it's ministry controls or personal protective equipment, both are vulnerable to human error, and so ultimately the system is in itself ineffective, so long as it relies on essentially a standard of perfection by humans. So it's inevitable that the system will break down in those circumstances. Now, you can do a lot. If that's all you've got, you can do a lot to improve the adherence to the system, the resilience of the system, and absolutely, and that happens when that's all you've got. But now we've got more. Now we've got vaccines. And so because we now have vaccines, then that has to be the solution, overwhelmingly, rather than relying on the less effective controls. So the way to kind of express it is that the safety 2 perspective on vaccination would be the same attitude that a safety 2 would have in relation to, in a traditional construction setting, edge protection versus harnesses. I mean, they're both safety controls, but one is a less effective control, which leads you into a cycle of blame the worker for not putting their harness when they have an accident, whereas the other one is a passive control where you can, by design, promote and enable the capacity of the workplace and the workers to succeed. So you're setting up the system for success. So for me, that is fundamentally how one needs to look at it. If you really want to get to the heart of what Safety 2 movement is really about, is about putting the workers back in the center of the conversation, putting people back in the center of the conversation, rather than constantly blaming them for the incidents that occur, because fundamentally no one turns up to work, or no one whether work or in fact walks around life wanting to injure themselves or injure others, and so that cycle of blame, I think, needs to end, and the more that we're relying on things that will inevitably break down, the more that we are still in that vicious cycle of blame.
Sure. That's really interesting. Mary Louise, I'd love to know your perspective on vaccine mandates.
Wow, where do we start with this? So, look, I concur with all the speakers talking about blame, that blame game, and every morning during the presses where a premier may talk about how many cases there are and how many were or were not vaccinated. I don't know if they are mean to blame, but instead of just saying there were 10 people and sadly 8 of them weren't vaccinated, they go through each age group and each gender and then label them as vaccinated or unvaccinated or partially vaccinated. So I find it very unhelpful. I think it's I think what they're trying to do is educate the public into understanding the importance of vaccination stops you from being hospitalized and reduces your risk of death. But the way it's done is very victim blaming, and it's very unhelpful. And also, it doesn't respect those that have died because of this cloud of, well, it's your fault you didn't get vaccinated. We don't know why they didn't get access to the vaccine. So that certainly doesn't help. But let me just take you all the way back to the limousine driver, if you wouldn't mind. Now, the limousine driver, that man was, there was a breach in the quarantine hotel system. That man should have been vaccinated. His family should have been offered the vaccine. And had he not been able to take up that vaccine for multiple reasons, that man should have had multiple testing availed to him. So there was a systems error. That driver didn't necessarily become the error. There was system errors for around that man. And one of the system errors was, why weren't the crew from the plane that came in, the cargo plane, why weren't they tested the instant their feet hit terra firma with a rapid antigen test? So there are issues. And I think that blaming and the thing that you do in patient safety, as Sue will explain, is that you walk through it to see where things can go wrong and, hop in a car, go and pick somebody up and work out where things can go wrong. So I think there have been failures in the system that's been developed rather than expecting all of the workers to constantly comply. There should be a system where it's very difficult not to comply. But getting back to vaccines, one of the groups that could have helped right from the beginning, who I imagine would have been desperate to help, were the business. Business wants to get back to work, and rolling out the vaccine it's very, very difficult. We have experts in Australia who've rolled out, vaccines around the world in low and middle income countries, and they'll tell you it's very difficult. And to have so many businesses offer or want to be part of that solution, and they weren't taken up, and it became very medicalized. And rather than actually business offering to be able to do it, they could also offer to do rapid antigen tests. And I know that a bank, and I think I'm allowed to use the bank's name, the Commonwealth Bank, used rapid antigen tests in the hotspot at the moment in Sydney to ensure that they kept their staff safe, which I think is a fantastic use of science and safety. Other places like Kmart also are using them. And there are multiple other examples of where business wants to get involved to assist in safety of staff, as well as safety for the general community as well. So yes, vaccines, I think, have been handled fairly poorly, apart from acquiring the vaccine, just rolling it out. So at the beginning of the year, I started to talk about hubs because it's a classic way of rolling out the vaccine. And there was deathly silence, but the hub was just only one part of it. And then I talked about local government getting involved, because what we're not understanding is why people don't do things. And it's often because it's not that they don't want to, it's just that it's very difficult. You're either poorly paid, don't have time to stand in line for 5 hours to get the vaccine. So why not have the local council involved, where they can open up a shop that sadly has closed down because of the economy, and help roll it out so that you can hop off the bus after working in whatever essential service you do and get vaccinated, or walk to your local vaccine supplier. Because don't forget, young people don't always have a GP, and Sue will attest to this, that when you leave home, you often leave your family GP behind, and you don't think you ever need the GP anymore. You're young. Maybe if you need your prescription for the contraceptive pill, then you might see women more often. But young men, it's unlikely. And then, of course, GPs are very busy looking after their own patient load, and it's very difficult for them to fit in their non-patients in the area. So there were many ways that we could have done this, including council, businesses, etc. So I'll just leave it there, but they were my initial responses to a faulty system for safety when it revolves around vaccines.
Thanks, Mary Louise. I'm keen to get Sue's thoughts on that topic as well. But before that, I just wanted to check if Michael wanted to add anything on rapid antigen testing.
Oh, I think Mary Louise said it beautifully. I think there absolutely has been an underutilization of rapid antigen testing, and I think it's time that. And one of the things that concerns me in the recent amendments to the public health orders in New South Wales that relate to the 12 local government areas is that while rapid antigen testing was included in the orders initially, it was removed. And one of the things that a lot of businesses want to see is a deployment of rapid antigen testing as a solution, and actually the availability of that as a solution, particularly in relation to people who have a medical contraindication in relation to vaccination, because for that group of people who have a medical reason why they cannot be vaccinated, we still want them in the workforce, but we want them in the workforce safely, safely for themselves and safely for others. And it seems to me that unless we actually unlock that as an option, I think we will be missing a trick.
May I just say that rapid antigen tests are not the replacement for PCR for diagnostics, and outbreak managers see things differently. You don't want to diagnose everybody in the Greater Sydney or wherever you happen to live. You want to make sure that you're allowing life to get back to a safe place. And given that we are not going for zero anymore, we're going for suppression with good vaccine coverage. But you still can acquire COVID even if you've been vaccinated. It's a different method of using a screening test. It's a bit like when you come back through the airport, you don't get x-rayed to see if you're bringing in anything unsafe like drugs, you get sniffed. Well, this is a bit like the sniffer dog. It's not your x-ray. It's not the diagnosis.
Sue, would you like to add anything to that?
Sure, Guinea. Interesting discussion, and I'd like to start with something fairly broad, and that is the background in which we're having this discussion. That we're accustomed to looking at safety systems and adaptive safety and the engagement and trust of staff within organisations. So normally we'd be talking about an industry or an institution or a workplace. In this case, the people involved are trying to manage a whole of country system with politicians who are held to account for the outcomes, with advisors who may be political and may be clinical, who are held to account for the outcomes of their advice. And then with 20 to 30 million people who don't necessarily feel that they've ever been engaged as part of an organisation. So when we talk about engaging a workforce by making them feel empowered or giving them values that align with a particular organisation, there isn't such an organisation that we can gather everyone into our arms through. So that's why I think we have to think a little bit differently about safety culture when we're dealing with a whole country. What that leads me to think then is that we should have been thinking as if there were a multitude of different countries. There are some countries or organisations where people can work at home instead of at the office, like Michael can and I can. Then there are countries where people do manual work, the building industry, transport, a whole lot of countries like that, where that workforce may not even have a computer, let alone be able to do their work at home. And even if they did, the rest of us wouldn't be able to eat. So what I think we needed to do was to not see the country as one single entity, but not even as states, but to see it as a multitude of organisations that to some extent could have been self-governing in the way we brought this about. The next thing I wanted to say in a general and then a more specific sense is that we're also working within a society that has two big characteristics that I think can be difficult. One is extreme risk aversion paired with high expectations, to the extent that people say no single child should ever die of anything, essentially, which obviously we all aspire to, but isn't reality. But at the same time, we're living in a culture that rejects expertise and elitism and sees the holding or speaking about expertise as if it was excluding them. And there's a sense in many areas that everybody's opinion should hold equal weight. And that sort of then expands into I have the right to speak and to be heard sort of culture. So on top of that, we've brought about an enormous exercise in vaccination with a big paradox. And the paradox is for half of the population, it couldn't happen fast enough. And for the other half of the population, they don't want to touch it because it's happened too fast. And so there's a whole lot of hesitancy related to the fact that this is all new. We've never done it before. Nobody's ever developed a vaccine so quickly. How do we know it's going to be safe? And then how could they force us to do that when we're not quite sure? And so I think the society we live in has forced us to have a whole lot of complications that make what seems to be logical, like get everybody vaccinated as quickly as possible so we can reduce other restrictions, it's become a bit of a quagmire that hasn't been assisted by the way it's been communicated. I might just stop there for now, but I think there's more to be said about the communication and engagement strategy.
Sure. I think that's your reflections on the society at large and what it represents, the way we're reacting to this pandemic are quite interesting. And it makes me think a bit about the trust equation. And Kelvin, I wanted to bring you into the conversation. In your view, what is the nature of the trust equation as it stands now? And would it have been different if we used the safety differently approach?
I think Sue was really touching upon this concept really well, about how the nature of the trust equation has been played out. And Mary Louise is also indicating the nature of our daily press conferences and in essence, the finding of people at fault being implied or otherwise in that process. And there's whole communities now that feel disengaged or not trusted in what they've got to contribute into that process. And I think where you're going, Sue, and I sort of feel the same, is that if you want people to participate, you've got to partner and have them, feel like that they've got some input and their opinion is valued and their voice is valued, and then you can actually lead a discussion that gets to a mutually beneficial path. But I might pass that to Sydney, because I think, Sydney, you might have some thoughts in that space as well.
Thanks, Cal. Yeah, there's some fascinating safety too, or safety differently aspects are recognized in the contributions so far, which Marie-Louise, I love the way in which you talk about the removal of obstacles in how you actually do a vaccination rollout and control these sorts of things. The removal of obstacles in conversation and engagement with those for whom you want to remove those obstacles is a critical aspect of safety differently, safety too, right? The question often being, not, why are you violating? Why are you not doing this? No, but the question then becomes, why does this make sense to you? What is the obstacle that keeps you from doing this, right? And so that's beautiful. I think the other thing, initially, of course, as soon as you talk about a mandate that's imposed from the top down, safety one bells go off. Whoa, that sounds very safety one. We mandate that thou shalt be vaccinated. But ultimately, of course, both testing, even if it's sniffer dog quality testing, it's better than not having a sniffer dog, I suppose. But particularly vaccination, of course, is all about building capacity, right? And safety too, safety differently, has always been about understanding capacities that make things go well. Well, the strongest capacities that make things go well is knowing whether you're infected or knowing that you're inoculated, other people around you are inoculated. And so very quickly, that becomes sort of a utilitarian argument that removes most, I think, objections, safety one type objections to a vaccination mandate, because the objections or fears of the few will quickly be overrun by the advantages for the many. And so, yeah.
May I just add something here? Sydney, what I find surprising is we love the fact that we're a multicultural, multi-faith society, and yet I haven't really seen a lot of evidence that we are bringing in those leaders and groups, let alone the young, because the young are acquiring COVID and spreading it. 69% of cases in hotspot areas, as in the Greater Sydney, are under 40. And we haven't identified.
You sound like the premier at a press conference now.
Well, no, except for they haven't identified why. They haven't contextualized how to protect them and what is going on. And they haven't identified whether or not the fact that they are so poor that they need to escape their 5-kilometre zone to be able to get cheaper food or go to cousin, Vinny's place for dinner because, and then they get infected because they can't feed their families. So what we haven't done while we are embracing multicultural, multi-faith is to actually use it and enable society and remove those obstructions.
Mary Louise and Sue, you touched on an important sort of safety differently concept of building collaborative partnerships. And that is a key mindset that underpins a safety differently approach, sort of the preparedness to broaden the arena of engagement, which is in stark contrast to keeping decision-making and control very tight. Yeah. I'd like to get Kelvin and Michael's opinion on that. Anything you'd like to add?
I might just touch in here. I know Michael will have something to say on this as well. But this engagement and collaborative partnership is a very key concept, and do it before the problem rather than after the problem. But also bringing into the concept of thinking about how we can be a bit more adaptable. And we talk about a lot in our thinking freedom within a framework, and understanding, if you just apply one set of solutions globally to everything, it's not going to work for a whole range of contexts. But so I thought, Michael, you might want to make some comment maybe on, that thinking, that what we need to do is introduce some of the thinking that we use around freedom within a framework.
Yeah, thanks, Colvin. In many respects, we actually we're heading towards that. When we get to 80% vaccination, that seems to be the intent under the agreed national plan, and there's an element of freedom within a framework within that, in the sense that when we get to the point of 80% vaccination, there will be certain rules and certain protections, particularly for unvaccinated people and the vulnerable communities, but there'll be greater freedoms in a sense for individuals who are vaccinated. But some aspect of that just feels like a bit of a carrot, and actually going about it in a back to front way. And in many respects, what should underpin this whole debate is transparency in education. And actually, sometimes saying we don't know can sometimes be a powerful way of bringing people along, or this is the best that we know about this issue, rather than definitively saying something and then flip-flopping on the same issue a short while later, because that undermines confidence. What you want to be doing is actually engaging with the community, being transparent as much as possible with it. And I mean, before I get to the concept of the creating barriers and rules where necessary, but only where necessary, and creating freedoms, the freedom within frame, as we talk about it in the Safety 2 movement. I mean, I just want to emphasise the idea of empathy here, and I think Mary Louise touched on it, and Sue did also. So did both of you, Kelvin and Sydney. In a sense, there seems to be a particular perspective of this pandemic that is, with respect, our perspective, which is a privileged perspective, right? We're often surprised by the plight of people who are, having to do 3 jobs and to make ends meet, for whom taking a day off or 2 is not really an option, because there are serious consequences for their welfare. And unless we engage with empathy in relation to those situations and actually try, and as Mary Louise said, try and work through preemptively solutions. As a country, as states, as organisations, we're going to be vulnerable to those type of outbreaks and misalignments that we have experienced, because people just are in a by necessity have to do things in a particular way. And we talk about it for the audience who will no doubt be listening to this, who understand or have heard us talking about some of these concepts. We talk about this quite often in relation to why workers deviate from the plan. Well, they deviate from the plan not because they think that it's a good idea to do that, and in a sense that they think it's, they're doing it for giggles. They do it because of necessity. They don't have the resources or tools to do the things that the plan had anticipated they would have, and the show must go on, and so they make the best that they can with the circumstances in which they find themselves in, and actually kind of being shocked and surprised every time things go wrong in that context, and then reaping in the rewards when they don't go wrong, and saying, oh yeah, they must have gone to plan. This kind of willful blindness to the reality that people find themselves in is the heart of the problem from a safety perspective, and it's exactly where we find ourselves here in relation to this pandemic. It's exactly that situation where we're all shocked that people are living in small accommodation, shared accommodation with multiple people in the same apartment or same small accommodation. We're shocked that people have 3 jobs and are in a warehouse in the morning, are delivering making deliveries and doing runs as shared drivers, and we're shocked that that this happens. Well, why aren't we inquisitive? Why aren't we curious? Why are we proactively asking how the world lives and how things happen? And why are we approaching these problems from the privileged perspective of that as Sue said earlier, it must be that everyone can work from home. It must be that.
Michael, I mean, aren't we a bit behind the curve if we have to wait for a pandemic to show us these misalignments in social justice? Because this is obviously what it's ultimately about. And I think,
and in fact,
yeah, go.
I was going to say, and in fact, remember we have just done a census, and the census will have How many
know.
people?
No excuse not to know. You're right.
We know.
Yeah.
Knew that the Western Sydney had more people living in the one household on average than other areas. This was not a surprise. And we would know what the income is. And we should therefore know that they may struggle to find cheap food within that 5 kilometre radius.
But Marie-Louise, does this not take us back to Kelvin's earlier point about the engagement of other types of expertise and inputs? I mean, his very first point that he made, right? I mean, is this somehow linked also, Michael, to the very selective recruitment into the medical profession in this country, right? That come from a select number of mostly private schools.
But also outbreak management. I mean, outbreak management has to have people from the area that you're trying to manage.
Those communities.
Yes, exactly. So that they can actually say, well, actually, maybe
that's not going to work.
Exactly. They're not complying because they can't afford to buy the bread from the nearest shop. They've got to go further. It's pretty simple.
But it's not even about complying. I think as long as we keep that mindset and using that word, we're still imposing our view on it. They are complying. They're complying with the constraints and demands of their lives and their hungry kids and their job requirements. They are complying.
I think the other interesting factor too is around the youth factor. You're talking about the young people, Mary-Louise, and their thing. We live in Melbourne. And we've lived in lockdown for, depending on who you talk to, more than or less than 200 days. There's, our young people, when we said, used to rely on their social connection through their phones, have realised that social connection and actually, getting together is a very important, need, in fact, we've actually put them into a condition often, where they're very disconnected and cut them off from all their social context, and the screens are not satisfying that need. And so I think there's a point of empathy in thinking about it's not just, the living conditions, there's actually, psychosocial conditions that we need to recognise and adapt and think about how do we actually respond and meet those needs as well.
Can I also bring in one of the important elements of safety, and that is ethics. So Michael talked about, reaching 80%. And I feel like I'm constantly harping on this. You cannot or should not be developing some sort of threshold if it's unethical. And my point is how can safety be so simple as to say across the board we're going to open up when we've reached 80% of the adult population, when, mind you, 100% of the total population are now at risk of Delta. But not everybody who is eligible for the vaccine has had access to the vaccine. And so therefore, by saying we're going to lift restrictions when we reach 80%, leaves behind the very group that are those that acquire COVID more often and drive it, and that's the young. So you're going to leave them behind.
Can I add to that, Mary-Louise? Because we talk a lot about this 80%. I think it's interesting how we use that term, because you're touching into now what the population vaccination is. And as my understanding, somewhere between 61 to 63% will be the actual vaccination rate, with that 80% marker. And so I think that's where you're getting to. We've got a very large proportion of the population who will not be protected under...
That is correct. So the 16 years and over, which was part of this model that was accepted, represents 80% of the total population. So 80.8 times 0.8 is 64% of the total population. So that's basically 1 in 3 will not be protected. And guess who that 1 in 3 will be? And it's not ethical. And that is the young. So at the moment in New South Wales, the 60 and over have had 2 doses, 62% of them. The 40 to 59, 51% have been double vaccinated. And guess how many haven't been double vaccinated in the 16 to 39? There's only 21%. So when we reach that 70 or 80%, it's going to basically be the middle-aged and the elderly. And the young are going to be that 1 in 3, at least, who have not had access, ethical access, And that's the part I find very, very difficult and, in fact, cruel.
Guinea, can I come in here? We've spoken about engagement and trust. We've spoken about removing obstacles, and we've touched a bit on the human behaviour aspects that make people do workarounds the way that they have to do. What we haven't spoken about so far is accountability for outcomes. And here I'd like to bring in the idea of thinking about what makes people behave the way they do in the realm of decision makers and policy makers. And this is something I think we often neglect, that people who are held to account for every minute mistake will be forced to behave in ways that are very much safety one rather than safety two determined. And to illustrate that, I think it's useful to think back to the time when vaccines were new. And I think it was an aged care home somewhere in Sydney where two elderly people were mistakenly given a slightly larger dose of vaccine than they should have been, which, when you think about vaccine doses, they're not that precise anyway, and there's no real fear of toxicity. And yet those two people became national news for giving a slightly bigger dose of something that didn't do anything to them except gave them immunity. And the way we react as a press, as mass media and as a population is to absolutely crucify anyone who made the decision or had anything to do with the way that came about. And so just like people with 3 jobs behave the way they have to do to put food on the table, people who make regulations and policy and decisions behave the way they have to do to keep their jobs or to not be seen as a murderer of their own population. And I think this is where we as a community need to take some responsibility for not threatening to turn over every state leader or prime minister or healthcare service leader where some imperfection happens. And I think that's what's influenced the way, for example, AstraZeneca vaccine has been discussed and promoted when the risks of complications are lower than nearly every medication that everybody takes every day. And yet we've created a situation where people are worried that something dangerous is being imposed on them. And our leaders are encouraging that by, on the one hand, saying you have to get it, and on the other hand, saying, but these terrible things are happening and we need you to know that they're happening. So I think a mature safety and quality system looks at all the tiers of decision-making and recognises the fact that people who are making policy and leading behaviour are just as prone to human reactions to the motivations, the forces that act on them, as the people in all the other rungs of the workforce are. But the impact is even greater. So I think it's worth concentrating even more on the way they behave the way they do, because they influence the way all the rest of us behave.
Yeah, that's a really interesting perspective, Sue. And just to expand a bit on the learning piece that has been touched on in part of the conversation today. So learning for success is a core component of the safety to approach. And I'm interested in the panel's views as to what they've observed in this domain as the pandemic has evolved. Michael, if you would like to start.
I think we are learning and we're learning every day, and I think the shift in approach away from counting numbers and counting incidents to talking about the vaccination capacity is an example of shifting from counting the absence of success to starting to give indications of actually measuring success. So that's a positive development in terms of the political discourse. I'd like to see us move away from this prescription type of approach and increasingly allow people to take a risk-based approach that protects the vulnerable, protects people that need the protection that are by the nature of their job and work in a higher risk category, but at the same time respecting that it's not a one solution for all. And if you're working from home, your position is not the same as someone who is at the front line of a shop or responding as a police officer or responding as an emergency service personnel, and therefore we should actually be, not prescribing as some recommend in terms of public health orders across the board, but rather stick to what we've always done in safety, which is give an objective-based approach, a principles-based approach, tell people what the objective is that you're trying to achieve, and give them the freedom to operate, to work towards that objective. That's how we've done it from a work health and safety perspective for 50 years, and the prescriptions and layers and layers of regulation have been abandoned a long time ago for good reason, and their re-emergence is for me a concern. So I'm hoping that eventually we'll move away and return back to that state.
Sure. And Sydney, would you like to add anything to that?
I think when it comes to increasing capacity, I think one of the learnings is that investing in early on in a series of possible vaccines, not putting all your eggs in one basket. One might presume that lesson has been learned, but also creating the possibility to onshore mRNA development and production to make sure that technology is available quickly. Of course, that is only as good as the distribution mechanism for it then, which Marie-Louise has commented on broadly and knows much more about. I would hope, and in fact would love to ask Marie-Louise, what learning do you see there in Australia? Are we learning to distribute this better? Setting it up for the next time?
Oh, look, one hopes at the end of every.
That's not a plan, though.
No. It's more of a hope. The World Health Organization put out a report last year. Well, actually, it was a report for WHO that basically said, look, we're in chaos. And you need to actually start working as a whole of community, whole of government, and whole of community. So everything we've been talking about, including the community, can be interpreted in that report, so that you learn and you plan, and that they really hope that this will be an opportunity not just to plan within country, but between countries as well, so that we share more. And having been somebody that worked very closely with China, I was actually very impressed after 2003 SARS outbreak that they actually wanted to learn what they did that was wrong, and so they could do it better the next time. And one of the things that I was very fortunate to write a report with somebody very high up in the Beijing Health Bureau, and we had said, what could have happened had the city been ring-fenced, Beijing? And that's exactly what they did with Wuhan. Now, we in Australia need to start learning. What could we do differently? Purpose-built quarantine systems, share the portfolio with vaccines, but even better, become a hub of vaccine developers. We have some of the best virologists and vaccinologists in the world, and we should be developing these. We should be, every time a new industry comes about, we should actually make sure that industry can flip and start to make PPE, for example, alcohol-based hand rub. So I think that it's a time to learn. And Sydney, I can only hope that we will learn. But one of the big problems that I foresee, and it's classic with government and completely antithesis of outbreak management, and that is transparency. Governments don't like to ever admit they're wrong, and Kelvin would understand this, having been very big in patient safety. They don't like sharing data because that shares mistakes, and we can only ever learn if we start to be very overt with the context of how things happen and how big that happening is, and where they could have done something different.
I can't reinforce that more, Mary Louise. So thank you for putting that. Yes, I fully concur.
I want to ask Mary Louise, how would you respond to the contention that we're always planning for the last disaster rather than for the next one?
Yes, that's divine. Sue, I think that's right. We go through these exercises, but in fact, we're not very good at saying what went wrong, because it basically means that governments, because it's usually governments that do this, and departments and staff, and it's very difficult to admit they got it wrong. And they often have on those reviews other department staff, such as hospital staff, for example, who work for the departments of health. And in fact, it needs to be independently run, and with, of course, government as a partner, so that they can justify, explain, and assist. But it really needs to be an independent one, just like we had with the Ruby Princess, for example. What went wrong there? The Diamond Princess, what went wrong there? What has gone wrong with the residential aged care facility, and how could that have been improved? So I think we're going to have more independent reviews, Sue.
But as I was alluding to before, the reason that a lot of government and authorities are so cautious about revealing error is the way we punish them for being responsible for error. And I think the only way to influence them to be more open is that what we hold them to account for is not perfection, but making the best compromise with the resources that they have.
Well, I think, Sue, it's now time. It's the new age for them to say, oh, I got that wrong. I'm going to now do a 180-degree turn. But governments don't like to do that. So democratic governments perform largely based on an economic performance, but outbreak management doesn't include any of that, and it's in fact very detrimental to the economy. So they need to understand we don't hold that up as a failure. It's going to be like that, and democratic governments are reluctant to share data, and yet the stakeholders need those data to make decisions about how well we went. So I think governments are going to have to be very, very strong in understanding it's good for them. It's good for the country. I mean, we are global citizens.
Yeah, sorry, Mary Louise, just conscious of time here. I didn't want to stop the rich discussion, but I'd like to just get the panel's closing thoughts, because we're about to close pretty soon. Any thoughts, Michael? Closing thoughts?
I think it's been well said by everybody, and I thank everyone for the opportunity to discuss this issue.
Sure. Sue?
Thanks, Guinea. I'd like to say something very broad, but I think it's pertinent, that empathy is probably the biggest word we can use in practicing any profession or job well, understanding why people behave the way they do, and expecting the best of anyone because they act according to the forces that control them. So I think if everybody works with the trust that people around them are trying to do their best and understanding why they sometimes don't, that applies to pretty much everywhere in life.
Sydney, any closing thoughts?
That was beautiful. Hear, hear. Thanks, Sue.
Kelvin?
Oh, yeah, look, I think for our governments to really take on trust and expanding trust, and doing that through transparency and engagement.
And finally, Mary Louise.
Yes. Kelvin, I couldn't have said it better. The only way we can improve is through trust, and trust with transparency builds cooperation. And the government needs to be mindful that we will trust them if they're open to full transparency, so that when there is another pandemic, and there will be, the World Health Organization has warned the globe that there will be, with climate change, there will be movement of populations and movement of novel viruses. And right now, governments need to practice trusting their constituents, and us trusting them.
Thank you. That's something for all of us to think about. I would like to thank all our panelists and our audience for taking the time to engage in this critical discussion. I'm also grateful to those watching who have raised questions in the YouTube live chat function. As I mentioned earlier, although the discussion part of this morning's session is drawn to a close, our panelists will be remaining online to respond to as many of these questions as we can. We do hope that today's discussion has been helpful in providing ideas or challenging our thinking, and that there is material here for you that you can use to continue to build thought leadership and engagement with others to enable us to transition to a COVID normal safely and sustainably. Finally, for everyone that registers, we will provide a link to the recording and a link to our COVID-19 Resource Center. The link to register is in the description of the YouTube video. Thank you.